extrahepatic biliary apparatus I will be discussing and explain the anatomical, this is the competency based undergraduate curriculum, and explain the anatomical basis of referred pain in cholecystitis, obstructive jaundice, mention the clinical importance of Calot's triangle, and describe and identify the microanatomical features of gastrointestinal system, gallbladder. In these headlines, you have to be preparing, and this can be a 10 marks question or 7 marks question. Now, the biliary tree consists of a duct system that collects and delivers the bile from the liver to the second part of the duodenum. It consists of intrahepatic part and extrahepatic part. Intrahepatic biliary tree drains exocrine liver and conveys bile to the extrahepatic biliary tree through right and left hepatic ducts. Intrahepatic biliary tree consists of the following: the bile canaliculus formed between adjacent hepatocytes. Okay, this is the bile canaliculus, this hepatocytes. Now, intralobular ductules or canals of Hardia, bile canaliculi drain into interlobular ductules. These are linked by simple cuboidal, lined by simple cuboidal epithelium. Interlobular ducts, the interlobular ducts drain into the interlobular ducts that run through the interlobular connective tissue septa. These ducts are lined by simple cuboidal and columnar epithelium and form the part of the portal triad. When you will be discussing the liver, the portal triad, now right and left hepatic ducts, interlobular ducts join to form the right and left hepatic duct that later join to form common hepatic ducts outside the liver. Okay. Now, bile flows centripetally opposite to the flow of blood in the sinusoids. Bile flows away from the central vein towards the portal triad. Duct of Laska, this can be a short note or MCQ. Duct of Laska, accessory bile duct, it is a small bile duct that drains into the gallbladder or into the right hepatic duct. It lies between the inferior surface of the liver and superior surface of the gallbladder. Now, now see the flow chart. Intrahepatic biliary tree hepatocytes, that bile goes to the bile canaliculi, canals of Herring or intrahepatic ductules, intralobular bile ducts, part of the portal triad, simple cuboidal and columnar epithelium, and right and left hepatic ducts, common hepatic ducts. Extrahepatic biliary apparatus, describe the extrahepatic biliary apparatus. The extrahepatic biliary apparatus or tree collects the bile from the liver through the hepatic ducts and delivers into the second part of the duodenum. Components of extrahepatic biliary apparatus, list the components of extrahepatic biliary apparatus. It consists of 5 components: 2 hepatic ducts, right and left, common hepatic ducts, gallbladder, cystic duct, bile duct. Now, this can be a short question. List the components of extrahepatic biliary apparatus. It can be just a 3 marks question or 4 marks question. So, hepatic ducts, right and left hepatic ducts collects the bile from the corresponding physiological lobe of liver. These ducts emerge at porta hepatis. Length of extrahepatic part of the right hepatic duct is about 1 centimeter and of the left hepatic duct is about 2.5 centimeters. At the porta hepatis, these ducts join to form the common hepatic duct. This is the right hepatic duct and the left hepatic duct, and this is the cystic duct, this is the neck of the gallbladder, body of the gallbladder, and the fundus of the gallbladder. This is the common hepatic duct. See, it is opening into the ampulla of Vater, and this is the main pancreatic duct. This is the head of the pancreas. This is the C-shaped, the duodenum. Plica circularis, this is the you will be seeing the histology of the small intestine. Now it is in folds because the function of the intestine is to absorption and digestion of food. Now this is monk's hood, major duodenal papillae, here's plica longitudinal, second part of the duodenum. Now you see the practice figure, this you have to see, this is the, you have to practice and draw when you are studying. Now you can also, when you are taking the notes, you can draw and like this simplified diagrams. The chapters which you are reading, you draw, you have a notebook and the textbook in the left side, not tab or something like that. You carry the tab when you are in movement. When you are going home and all this, in the train, you can look into the tab. So, because you keep on writing and then you memorize. Next. Now, extrahepatic biliary apparatus components. Now, hepatic ducts, right duct 1 centimeter, left duct 2.5 centimeters, drains into corresponding physiological lobes. Common hepatic duct, formation union of right and left hepatic ducts 3 centimeters long. Gallbladder, pear-shaped, blind sac, stores and concentrate bile, lies in the fossa of inferior surface of liver, 30 to 50 ml capacity. First, parts, fundus, body, neck. Now, in disease condition like mucocele of the gallbladder or empyema of the gallbladder, in is a condition mucocele. It is mucus that secreted, that is the gallbladder can be of it can be up to 6 inches, 7 inches, the pathological state of mucocele of the gallbladder. With an, it might be have an impacted gallbladder in the neck or Hartmann's pouch. Okay, and if this is infected, there's pus formed in the gallbladder, then it is known as empyema of the gallbladder. Now, cystic duct connects neck of the gallbladder to common hepatic duct, 3 to 5 centimeters long, has spiral valves of Hester. Now, common bile duct formation, union of cystic and common ducts 6 to 8 centimeters, termination fuses with the main pancreatic duct and opens into the second part of the duodenum. Now, clinical integration, cholecystitis, referred pain of gallbladder, Murphy's sign, Courvoisier's law and gallstones. These you have to know referred pain and what is cholecystitis. Next. Now, some interesting facts. The arrangements of structures at porta hepatis from anterior to posterior are as follows: hepatic ducts, proper hepatic artery, and branches of portal vein. Actually, it is one of the largest number of operations throughout the globe is being performed by the surgeons, and the gallbladder disease is in the rise. One thing. Another thing is that actually previous statistics were there before the pre-era of ultrasonography. You have a routine USG ultrasound of the abdomen, then a pain in abdomen or some fullness, acidity, you are prescribing. Even if the patient, what's happening, that patient, he or herself, referred by doctor, self. The sonology center or pathological centers, they are self. So one thing I would just say that those doctors are practicing in the village, in towns, villages, everything, cities. I tell them the SMD, self-made doctor. They have not passed MBBS or something. They are just practicing through the chemist shop, or they are giving service in the villages, interior villages. So I just say SMD, MBBS, MD, like self-made doctor, SMD. So the ultrasonal plate, the doctor referring doctor, self. It is the only country, I think, I don't know any other place, but that patients themselves, they go to the diagnostic center and say, Babu, at a peter photo kora din, ek USD cut dijiye. So they think it is self. Now, I'm just making a joke. Now, the common hepatic duct, the right and the left hepatic ducts unite at the right end of the porta apparatus to form common hepatic duct. It runs downwards for about 3 centimeters. Cystic duct joins with the common hepatic duct on the right side at an acute angle to form common bile duct. Now, this is the same picture. Now, accessory bile duct may open into the common hepatic duct. Okay. This is the common cystic duct, upper part of the bile duct, the gallbladder, and this is the ampulla of Vater. Now, some interesting fact is cystohepatic angle is the angle between the cystic duct and the common hepatic duct, the cystohepatic angle. This can be an MCQ question. Common hepatic duct lies on the right of proper hepatic duct artery and anterior to the portal vein in the free margin of the lesser omentum. When you see in the dead body, you will see the free margin of the lesser omentum, and also you can identify each structure. Whatever you are seeing here, or I am telling you, you can identify, you can dissect out every part. Now, accessory hepatic duct, it is observed in about 15% of individuals. It emerges from the right lobe of the liver and terminates at any one of the following: common hepatic duct, gallbladder, cystic duct, upper part of the bile duct. After cholecystectomy, removal of the gallbladder, bile may ooze in the peritoneal cavity from missed ligation of accessory hepatic duct. Hence, drain tube must be put in. Now, this is very important because the gallbladder, your cystic duct, what you do, laparoscopy or anything, you have to be sure that you have ligated and cut, otherwise there will be biliary leakage. You have any suspicion regarding that it might or might not, then put a drain. You put a drain in the subhepatic phase. And after surgery, it might be open cholecystectomy, it might be laparoscopy. Put a drain, it is the mirror that reflects anything you find. Next. Now you see this is the undersurface of the liver. This is left lobe, ligamentum teres, quadrate lobe, and this is the epiploic foramen, goes into the lesser sac. It can go into the lesser sac. And this is the lesser omentum, this is the greater omentum, and right lobe of liver. This is right lobe of liver. See, it's put in red. It has importance of, it might be, you get a short question, epiploic foramen, describe. You draw this picture and describe how it is there. Now, gallbladder is a pear-shaped blind ending diverticulum or sac attached to the biliary duct by its cystic duct. Functions of the gallbladder perform the following: storage of bile, concentrate the bile by absorbing water, releases of bile into duodenum, stimulation by cholecystokinin, absorption of small amount of bile salts, cholesterol complex. Now, see, if any fat meal or you take, then the gallbladder contacts, they call the cholecystokinin is the is responsible for the release of bile into the duodenum, stimulation by cholecystokinin. Now, location, the gallbladder lies in the fossa for gallbladder, which is located at the inferior surface of the right lobe of liver. Fossa for gallbladder extends from the porta hepatis to the inferior border of the liver. It is connected with liver by connective tissue. Next. Now, the same picture here. Now, this right hepatic duct, left hepatic duct, the common hepatic duct in blue, this is the cystic duct, and this is the Hartmann's pouch. This is the Hartmann's pouch, and you see the neck, body, fundus. This is the supraduodenal part and retroduodenal part of the common hepatic duct, and see interduodenal part here, and the main pancreatic duct, the major part of the duodenal papilla. Now, fundus of the dimension 30 to 50, length 7 to 10 centimeters, width 3 centimeters. This is normal, but it can be in empyema or mucosal of the gallbladder. It can be enlarged. Okay, fundus of the gallbladder. It is expanded free end of the gallbladder. It projects beyond the inferior border of the liver and comes in contact with the anterior abdominal wall at the tip of the 9th costal cartilage. Now, the relations, peritoneal relation, the fundus of the gallbladder is entirely covered by peritoneum. General relation, anteriorly parietal peritoneum covering the anterior abdominal wall at the level of the tip of the 9th costal cartilage. Posteriorly transverse colon. Now, this is next. Now, body of the gallbladder, it extends from the fundus to the neck. It is directed upwards, backwards, and to the left of the, to join the neck of the right end of the porta hepatis. It has two surfaces, superior surface, inferior surface. Now, it is contact with the inferior surface of the right lobe of liver. It is devoid of peritoneum and separated from liver by thin layer of connective tissue. Inferior surface, it is covered by peritoneum. It is related to the transverse colon at the first part of the duodenal inferiorly. Neck of the gallbladder is narrow part of the gallbladder that connects the body with the cystic duct. The junction of neck with the cystic duct is marked by constriction. Direction, the neck forms S-shaped curve, runs upwards and forwards, and then it turns down and backwards. See. Okay, relation, neck is related inferiorly first part of the duodenum and superiorly to the cystic artery and loose areolar tissue. Okay, next. Now, some interesting facts about Hartmann's pouch. It is an occasional small diverticulum projecting downwards and backwards from the neck. Isthmus of the gallbladder is the part of the neck that gives attachment to the Hartmann's pouch. Now, the gallstones will get lodged in Hartmann's pouch, which I told you just now, that gallstones may get lodged in the Hartmann's pouch. Mucous membrane of the neck shows spiral folding that prevents the flow of bile within and out of the gallbladder. Now, this gallstone is impacted if it is in the Now, if it is one single calculus will be impacted, or there will be a small stone here, the Hartmann's pouch. Now, if you do open cholecystectomy, then you have to palpate and feel that small calculi is lodged in the cystic duct or in your Hartmann's pouch. Because you do, when you are doing laparoscopic, this thing, they are still the steel clips to hold the thing. So, even if the gallbladder small stone is there in the cystic duct, it is not visible in USG or anything. But that does not pose any problem, but in case it is very difficult to take out, then you have to leave it. And see what happens. You get here is the stone. Now open cholecystectomy. What I do is that I take a suture through over here and lift it up, and I take a suture here and lift it up. See, like this, and hold it. Make a small incision in this part, and take out the stone that is impacted and lodged in the cystic duct or Hartmann's pouch. If it is hard to negotiate, there is the vessel is there, naturally profuse bleeding can occur if you mishandle. So you respect the dead body, you learn the dissections there, similarly you respect the human body, living body तो respect करना ही है, लेकिन dead body उससे ज़्यादा करना है. Okay, now interduodenal part, direction of common bile duct. You will be next. Now you see the sphincter of pancreatobiliary junction. Write a short note on sphincter of body. I told you earlier that the sphincter of body is sphincter of body here. You see just remember the picture, and this is the submucosa, this is the major duodenal papilla, this is the duodenum, and this is the common bile duct. This is the pancreatic duct. Sphincter is open, and wall of the duodenum, here is the wall, mucosa, submucosa, and circular layers of longitudinal layers of muscular extrada. This. Now, sphincter of write a short note on sphincter of OD. Now, the circular arranged smooth muscles around the pancreatobiliary junction from the following sphincters. The sphincter colodochus of Boyden, sphincter pancreatus around the main pancreatic duct, sphincter ampulla of OD, and the ampulla of Vater. These three sphincters are independent of duodenal musculature. They remain closed until the digested contents from the stomach enter the duodenum. So, as the food passes down the duodenum from the stomach, then these sphincters come into action. You remember that? And innervation. Innervation is the parasympathetic fibers and cholecystokinin hormone in the duodenum. Relax the sphincters around the pancreatobiliary junction. Clinical indication division of upper part of sphincter body is required during endoscopic retrograde cholangio pancreatography, ERCP. This is by endoscope. They inject the duct. If there is blockage or some growth, or when the patient is presented with a jaundice, and USG gives no image of gallstones, then you have to think it in terms that the sphincters might be affected, or there can be a small growth or tumor in this region, in this region. So accordingly, you have to be the ERCP, obstruction of pancreatic junction leads to jaundice. Next. Now you see, now blood supply, lymphatic drainage and innervation. Arterial supply, the gallbladder is supplied by superior and inferior branches of cystic artery. Superior branch supplies superior surface of the gallbladder, inferior branch supplies the inferior surface of the gallbladder. In addition to gallbladder, the cystic artery supplies cystic duct, hepatic ducts, and the upper part of the duct. Branches of the superior pancreaticoduodenal artery supply the lower part of the bile duct. Venous drainage, most of the venous blood from the extrahepatic biliary tree is drained by the cystic vein into the portal vein. This is important. Cystic vein into the portal vein. Small veins from superior surface of the gallbladder pierce the liver and drain into the hepatic veins. Lower part of the bile duct directly drains into the portal vein. Next. Now lymphatics. Now lymphatic drainage, lymphatics from gallbladder drain into the cystic lymph node of Lund and hepatic nodes that is alongside the upper part of the bile duct. All these nodes drain into the celiac group of nodes. Lymphatics from superior surface of the gallbladder drain into the intrahepatic lymph vessels. In addition to the gallbladder, the cystic nodes drain cystic duct and bile duct. Lower part of the bile duct drains into the hepatic or superior pancreatico-splenic nodes. So, innervation, gallbladder is innervated by branches from the hepatic plexus that carry sympathetic fibers from T7 to thoracic 9 segment of the spinal cord. These are vasomotor and motor to the sphincter. Now, this is vasomotor and motor to the sphincter. Parasympathetic fibers from vagus nerves. These are motor to the musculature of the gallbladder and bile ducts and inhibitory to the sphincter. A branch of phrenic nerve. Next. Now, এটা তোমার flow chart তুমি দেখে নেবে. Next. Now, this is one question, that is cystohepatic triangle of Callot. Write a short note on Callot's triangle. Write about the clinical significance of Callot triangle. Now, boundaries. This is important. Boundaries. This cystohepatic triangle of Callot is a triangular area, is bounded by the follows. On the right, cystic duct. On the left, common hepatic duct. Above, inferior surface of liver, apex directed downwards between cystic and common hepatic ducts. Now, the French surgeon, Callot originally described cystic artery as a superior boundary of Callot's triangle. Contains right hepatic artery, cystic nodes of Lunt. Next. Now, you see the contents of cystohepatic triangle, right hepatic artery here, the cystic artery is here, cystic lymph node is here. This is the triangle, yellow triangle. Boundaries above the surface of liver, inferior surface of the liver on the cystic duct, on the left common hepatic duct, apex and common bile duct. Next. Now, clinical integration. Now, in cholecystectomy surgery, the pedicle of the gallbladder is located in Callot's triangle and ligated. This is the part. This portion. Yeah. Okay. Now, Moynihan's or caterpillar hump is a caterpillar like loop of the right hepatic artery. This is the right hepatic artery. This is like this. And it's been mistakenly ligated along with cystic pedicle and cut during cholecystectomy. That leads to profuse bleeding. So, you have to be very careful with this area. Okay. Now, occasionally accessory hepatic ducts may be left behind unattended during cholecystectomy that causes oozing of bile from the wound. Cystic nodes of Lund are often enlarged. Next. Now, list of sites for referred pain of gallbladder. What is Courvoisier's law? Now, this is very important. You might get a question of 10 marks, referred pain and in cholecystitis. Now, cholecystitis is an inflammation of the gallbladder. It may be acute or chronic. Acute cholecystitis usually occurs in women. It presents with sudden onset of pain in the right hypochondrium that is referred to the inferior angle of the scapula and tip of the right shoulder. Now, when you are palpating and the abdomen, and if the patient is tender over here, and you ask that does this pain is referred to your shoulder or the inferior end of the scapula, inferior angle of the scapula. Now, symptoms are aggravated on taking fatty meals as it stimulates more contractions of gallbladder for bile release for fat digestion. Now, chronic cholecystitis usually occurs in fair, fatty, fertile female of 40. 5F. So, chronic cholecystitis occurs in fair, fatty, fertile female of 40 years of age. It is prone to gallstone formation. Referred pain of gallbladder, some fibers from the phrenic nerve C3, C4, C5 supply the subdiaphragmatic parietal peritoneum, and the gallbladder, the pain from gallbladder gets referred same dermatomes, the nerves which supply your muscles and skin, the dermatomes. When you are reading embryology, it will be explained to you. Now, the pain from the gallbladder gets the pain from the gallbladder gets referred to same dermatome, especially in the following sites. The pain from gallbladder gets referred to same dermatome, especially at the following site: to the tip of the right shoulder, supraclavicular nerves, C3, C4, to the inferior angle of right scapula by sympathetic fibers, T7, spinal segment. This is very important. With this chapter means in your viva you will be asked, especially cholecystitis in referred pain, and it can be as a short question. That is one thing, and that can be the MCQ. So you accordingly you just prepare yourself and see, it is not tough. You go and draw diagrams and label them and depict and read. Okay? Now, Murphy's side is elicited in patients with acute cholecystitis by asking the patient to take in and hold a deep breath while palpating the right subcostal area. If pain occurs on inspiration, when the inflamed gallbladder comes in contact with the examiner's hand, Murphy's sign is positive. Now, নিঃশ্বাস নিতে বলবে, deep, and you palpate, and ছাড়লো, তখনই তো Now, Murphy was a surgeon. He was attacked with acute cholecystitis and he was lying in his bed. So he just palpating, and he was feeling, and he called the sister, hey, come, and please note what I am telling. So that's how Murphy's signs means Murphy discovered, I would say, rather, and that he was as a patient, he was entered for surgery in London hospital, and he just, when he was suffering from agonizing pain and all, but he still went and said, what is the problem with my tummy? Okay, and then he, that's why it's known as Murphy's sign. Biliary colic is a pain that occurs due to spasmodic contraction of smooth muscles of the gallbladder, especially to expel the gallstones. The obstruction of common bile duct occurs due to gallstones, periampullary carcinoma, I told you, and enlarged lymph nodes. It leads to obstructive jaundice. Now, in these things you can do, you have to go now in modern investigation, ERCP, MRCP, for the MRCP, ERCP. And if there is a gallstone lodged there, it is very difficult to take out with the endoscope. Then, but there is a jaundice of say 10, 5. Just Vishwajit told you about jaundice, a rare encounter of the patient. 5 to 6 cases reported in the world, and he reported one case. So you just report korte dile, you go for routine LFT, routine CBC. You please note and see the bilirubin level, and then you go to ask the patient to have your imaging. You first do USG. That might be cholecystitis with stones in the gallbladder. CVD, also CVD is there. This is one part, or cholecystitis stone with jaundice, but no stone in the CVD. Possibility there is no stone in the CVD. Now, accordingly, you have to manage according to the condition, and there will be any tumor lodged. Now, I tell you that, see, when there is some small tumor in the sphincter of OD or pancreatic head, large tumor, there can be the common the ducts, that is pancreatic duct and your CVD. Now, that you have to do endoscopic and put a stent there to drain the bile, let the jaundice go down and go for further investigation. And then usually what happens, there are many types of bypass operation. This part, now you have to just correlate in your dissection and your the part in the gross anatomy. You please go to your respective classes, and I'll just you have histology, small intestine.